Okay, let's dive into this. Welcome to our Interstitial Lung Disease Masterclass Explainer, crafted specifically for the MSRA. If you want to absolutely conquer the respiratory section of your exams, you are in exactly the right place. We are going to break down the high-yield facts, the classic presentations, and those sneaky diagnostic traps that examiners just love to test. And hey, make sure you stay sharp, because I'm teasing a rapid-fire 10-question quiz at the very end to lock all this knowledge in.
Here is how this masterclass is going to build. First, an overview and zonal rules. Second, occupational hazards. Third, IPF versus sarcoidosis. Fourth, high-yield mnemonics. And finally, number 5, that rapid-fire MSRA quiz. All right, kicking things off with Section 1, Overview and Zonal Rules. Understanding the basic pathophysiology here really sets the stage for everything else. So at its core, interstitial lung disease, or ILD, is this whole heterogeneous group of disorders that cause inflammation and fibrosis. But clinically, what you actually need to spot on a spirometry report is a restrictive ventilatory defect. Your absolute key exam phrase here is impaired gas diffusion capacity, meaning a severely reduced transfer factor, or TLCO. Whenever you see a restrictive pattern paired with a dropping TLCO, your diagnostic alarms should literally be ringing for the interstitium.
And this brilliantly illustrates one of the most powerful diagnostic tools in your arsenal, spatial mapping. Different diseases just love different parts of the lung. For upper zone predominance, we use the classic acronym CHARTS. That's col, histiocytosis, ankylosing spondylitis, radiation, TB, and silicosis or sarcoidosis. On the flip side, for lower zone predominance, think ASCO, asbestosis, scleroderma, cryptogenic or IPF, and certain drugs like Amiodarone or Methotrexate. Take a mental snapshot of this. Knowing exactly where the fibrosis sits on a chest x-ray instantly narrows down your differential. Moving right along to Section 2, Occupational and Environmental Hazards, because let's face it, your patient's job is often your biggest diagnostic clue. An occupational lung disease and employment history is basically your best test. Got a retired shipbuilder or a plumber? You're definitely hunting for asbestosis, which means lower zone fibrosis and benign pleural plaques. What about a stonemason or sandblaster? Think silica dust, upper zone fibrosis, and that classic eggshell lymph node calcification. For minors, look for the upper lobe opacities of coworkers' pneumoconiosis. And hey, if they also have rheumatoid arthritis, boom, you've just diagnosed Kaplan syndrome. Lastly, if they work in aerospace or electronics, think beryllium exposure leading to berylliosis, which actually mimics sarcoidosis with its non-casing granulomas. Now listen up, because here is a massive exam trap. Everyone associates asbestos with mesothelioma, right? Well, while that link is completely real, bronchogenic carcinoma is actually the most common overall malignancy associated with asbestos. It's a numbers game. Plus, there is a massive synergistic risk if that asbestos-exposed patient also happens to be a smoker. So don't fall for the trap. Bronchogenic carcinoma is the #1 cancer by frequency here, hands down. All right, Section 3, Idiopathic and Systemic. We're putting IPF head-to-head against sarcoidosis.
Let's build the classic IPF patient profile. Picture this clinical story in your head. A male patient, usually an ex-smoker, somewhere between 50 and 70 years old. He walks into your clinic complaining of progressive exertional breathlessness and this stubborn, dry, non-productive cough. You examine him, you spot finger clubbing, and when you listen to his lung bases, there it is, fine end-inspiratory crackles. The absolute trigger word you need to hunt for in a question stem is Velcro crackles. You order a high-resolution CT, which is the gold standard imaging here, and the radiologist reports peripheral, subpleural reticulation and honeycombing. Seriously, Velcro crackles and honeycombing? You're looking straight at idiopathic pulmonary fibrosis. So, keeping IPF in mind, what is the clinical significance of 50 to 80%? Well, this is the strict NICE guideline window for initiating antifibrotic medications like pirfenidone or nintedanib. To actually qualify for these disease-modifying drugs, the patient's forced vital capacity, their FVC, must specifically fall between 50% and 80% of their predicted value. Oh, and a super quick clinical pearl. Steer clear of routine oral steroids and IPF. They actually increase morbidity and mortality, so just don't do it. Shifting gears over to sarcoidosis, you absolutely, unequivocally must know Lofgren syndrome. This is an acute, famously benign presentation of sarcoidosis. It's defined by a very specific triad. Erythema nodosum, those tender red nodules usually popping up on the shins, plus bilateral hilar lymphadenopathy, or BHL, on the chest x-ray, and finally, polyarthralgia with a fever. The really great news for patients with Lofgren is that it frequently resolves completely on its own within a year or two, without any aggressive treatment. In stark contrast to that, we have Hofford-Fort syndrome, which is also known as uveoparotid fever. Try to visualize the distinct facial and ocular symptoms here. This is a sarcoidosis tetrad consisting of anterior uveitis in the eyes, prominent parotid gland enlargement, a facial nerve palsy affecting cranial nerve 7, and a fever. It's an incredibly visual clinical presentation, which makes it absolute prime fodder for exam questions. Let's move to and see how this builds radiographically using the scatting staging system for sarcoidosis. It logically tracks a linear radiographic progression. Stage 0 is just a totally normal X-ray. Stage 1 is bilateral hilar lymphadenopathy alone, and remember, asymptomatic stage 1 means absolutely no treatment. Stage 2 adds infiltrates to the BHL. Stage 3 is infiltrates alone, without those enlarged lymph nodes. And finally, stage 4 represents the end-stage destruction, meaning fibrosis and honeycombing. Moving right into section 4, high-yield mnemonics, because rapid recall is the name of the game for your exams. Lock these memory anchors in for test day, guys. For the spectrum of asbestos disease, just use PLAM, plaques, lung cancer, asbestosis, mesothelioma. For your zonal rules, it's simple. Silica up, asbestos down. And for the Lofgren syndrome triad, just think of the name BA. Bilateral hilar lymphadenopathy, erythema nodosum, and arthralgia. Commit these to memory, and you're going to save yourself precious, precious minutes during the exam. All right, section 5. Wake up and get ready, because it is time for the rapid-fire MSRA quiz. Let's actively test everything we've just covered. Let's fire through these first 3. Question 1. What is the definitive imaging choice for idiopathic pulmonary fibrosis? That would be the HRCT, looking for that peripheral honeycombing. Question 2. What is the highest frequency malignancy associated with asbestos? Don't fall for the trap, it's bronchogenic carcinoma, not mesothelioma. Question 3. What is the classic lymph node radiographic sign in silicosis? You're looking for that eggshell calcification. Pattern recognition is absolutely key here. Let's keep the momentum going. Question 4. A patient has shin nodules, arthralgia, and bilateral hilar lymphadenopathy. What's the diagnosis? That is the benign Lofgren syndrome. Question 5. What is the spirometric profile of IPF? It's restrictive, meaning a decreased FVC with a normal or increased ratio. So the crucial point is really knowing your spirometric patterns inside and out. Question 6. Silicosis significantly multiplies the risk for which specific pulmonary infection? That's tuberculosis, often referred to as silicotuberculosis. Almost there, let's finish strong. Question 7. Do benign asbestos pleural plaques require follow-up? Nope, they are completely benign with zero malignant potential. Question 8. What specific mechanism causes hypercalcemia in active sarcoidosis? It's the uninhibited 1-alpha hydroxylase activity inside the macrophages of the granuloma, which converts vitamin D. Question 9. What FVC range is required by NICE for IPF antifibrotics? That golden window of 50 to 80% predicted. And question 10. The combination of rheumatoid arthritis and Kohlwerker's nodules is called what?
Almost there. Let's finish strong.
You now have the structured knowledge to tackle interstitial lung disease on your exams with total confidence. But as you continue to study, I want to leave you with this thought. As our understanding of cellular mechanisms like macrophage activity and fibroproliferation grows, how will future targeted therapies eventually reshape those currently irreversible Velcro crackles of fibrotic lung disease? The science is moving incredibly fast, and what seems permanent today might actually be curable tomorrow. Keep that curiosity alive. Keep mastering those structures, and best of luck with your continuing studies.